Okay, let's dive right in. Today, we're going to break down the diagnosis and initial workup of diabetes in adults. Think of this as your high-yield guide to getting it right from that very first lab results. So you get that lab alert, your patient's glucose is high. What's the very first question you should ask? It's not, how high is the number? Nope. The single most important first question is this: does my patient have symptoms? Because that one answer is going to determine the entire diagnostic path we're about to walk through. And that question, right there, brings us to our first section. The clinical presentation is the major fork in the road. Are we dealing with a quiet incidental finding or a full-blown symptomatic picture? And as you can see here, the presentations are often like night and day. Over 90% of type 2 diabetes is found totally by accident on routine labs in a patient who feels perfectly fine. Contrast that with type 1, which often shows up with a bang, with that classic triad of polyuria, polydipsia, and weight loss. And here's a crucial point for an adult patient. About a quarter of them with new onset type 1 will present in a medical emergency called DKA, or diabetic ketoacidosis. But why do these symptoms even happen? Well, it all boils down to this process called osmotic diuresis. When your blood sugar gets crazy high, your kidneys just get overwhelmed. They can't reabsorb all that glucose. So glucose starts spilling into the urine, and it acts like a sponge, pulling a ton of water right along with it. And that is what causes polyuria, or excessive urination. So what's the trigger point? There's a magic number you have to know: 180 milligrams per deciliter. This is the renal threshold for glucose. The second your blood sugar crosses that line, the floodgates open in the kidneys, and that cascade of polyuria begins, which of course leads to dehydration and intense thirst, or polydipsia. This one number explains the whole domino effect. Okay, so we've got the symptoms down. Now, how do we translate that into an official diagnosis? Let's get into the hard data, the numbers you absolutely, positively have to have memorized. Remember that first question we talked about, symptoms or no symptoms? Well, if the answer is yes, my patient is symptomatic, then your job just got a whole lot easier. You don't need a complex workup, you just need one number. And this is the rule. Plain and simple. If a patient comes in with those classic symptoms we've been talking about, and you get a single random plasma glucose of 200 or higher, you're done. That's a confirmed diagnosis of diabetes. No repeat test is needed. But what about that much more common scenario, the asymptomatic patient? Here, things are a little different. The American Diabetes Association gives us 3 main ways to diagnose. You can use an A1C of 6.5% or more, a fasting plasma glucose of 126 or more, or a 2-hour glucose of 200 or more during an oral glucose tolerance test. Now, this is one of the most important takeaways for asymptomatic patients. You must confirm the diagnosis. I can't stress this enough. This is a critical step to prevent misdiagnosis. Labeling someone with a chronic disease like diabetes is a life-changing event, so we have to be 100% certain. You can either repeat the same test on a different day, or if you have 2 different abnormal tests from the same blood draw, say both the A1C and the fasting glucose are in the diabetic range, that also seals the deal. Before we move on, there's a critical in-between stage we need to talk about. This is the warning zone, where patients aren't diabetic yet, but they're definitely not normal anymore. This is prediabetes. And just like diabetes, prediabetes has its own set of numerical cutoffs, an A1C between 5.7 and 6.4%, a fasting glucose between 100 and 125, which we call impaired fasting glucose, or IFG, or a 2-hour glucose tolerance test result between 140 and 199, which is known as impaired glucose tolerance, or IGT. Catching patients in this stage is a huge opportunity for prevention. Okay, so you've nailed the diagnosis. Now what? The next crucial step is figuring out what kind of diabetes you're dealing with. Is it the far more common type 2 or the autoimmune type 1? Your clinical judgment gives you a ton of clues here. You should really be thinking about type 1 if your patient is on the younger side, say under 35, if they're lean, if they present with super high blood sugar, or if they have signs of catabolism, like significant weight loss. A personal or family history of other autoimmune diseases is another major red flag. But, medicine isn't always so clear-cut. You might have an adult who doesn't perfectly fit the profile for either type. So how do you get a definitive answer when you're in that gray zone? This is where we turn to the lab for a definitive answer. 2 key tests. First, we check for islet autoantibodies, like anti-GAD65. A positive antibody test confirms an autoimmune process, pointing straight to type 1. Second, we check a C-peptide level. C-peptide is released with insulin from the pancreas, so a very low C-peptide level when the blood sugar is high means the pancreas simply isn't making enough insulin, which is the hallmark of type 1. All right, let's bring it all home. We've got our diagnosis and we've determined the type. So what's the essential lab panel you need to order for every new patient to get a really solid baseline?
Here's your go-to checklist: a baseline A1C to track future control, a fasting lipid profile, since diabetes is a major cardiovascular risk factor, liver function tests, or LFTs, and critically, we need to assess kidney health. That means checking a serum creatinine with an eGFR. And to screen for the very earliest signs of kidney damage, we order a spot urine albumin to creatinine ratio, or UACR.
Now hold on, there's one extra really crucial step specifically for patients with newly diagnosed type 1 diabetes. Because it's an autoimmune disease, you absolutely have to screen for other autoimmune conditions that love to travel with it. And these are the big two to screen for right at diagnosis. You'll check for autoimmune thyroid disease with a TSH, and for celiac disease, which can often be totally silent, by checking tissue transglutaminase antibodies. So, to wrap this all up, if you take nothing else away from this, burn these numbers into your brain. For diagnosis, it's a fasting glucose of 126, a random or 2-hour glucose of 200, or an A1C of 6.5%. These are the gatekeepers to diagnosis. And let's end with this, the 2 golden rules from today's explainer. If your patient is asymptomatic, always confirm an abnormal result, and if you have any clinical suspicion for type 1 diabetes, don't guess. Check the antibodies.